Well, those of you who have stayed are, I think, in for a real treat. This is one of my favorite topics when it comes to public health, health systems, because it is absolutely essential for everything that takes place domestically and globally in health. And it is one of the hardest things to garner support for. And so I'm really looking forward to the comments of our four panelists. I was involved in a panel in New York a week ago when Save the Children announced a big initiative around trying to train 1 million frontline health workers. And it all came down to that being essential for health systems around the globe to have impact in so many diseases. So our four panelists, Mike Haglund is Professor of Surgery, Neurobiology, and Global Health. Manoj Mohanan is Assistant Professor, Public Policy and Global Health. Moshi Ntabaye is Executive Director of the Kilimanjaro Christian Medical Center in Moshi, Tanzania. And Kate Whetten is Associate Professor, Public Policy, Nursing, Community and Family Medicine, and Global Health. And Mike's going to kick it off.
All right. So what I'd like to talk today about is some of the work we've done in East Africa over the last several years through the Global Health Institute. If you look at the population map of physicians in the world, you can see there's a very significant shortage in the central part of Africa compared to the rest of the world. And it's even more pronounced when you look at subspecialties like neurosurgeons, where in the United States we have 4,600 neurosurgeons and there's only 565 in all of Africa. When you look at different countries, Africa you have to break into two parts, the northern part of Africa and South Africa, the country, and the middle part of Africa, especially East Africa. If you look at two countries, Morocco and Uganda, you can see that in Morocco they have about the same number of people as Uganda does, but they have 171 neurosurgeons, which is a ratio of about 1 to 187,000. In the U.S., we have about 1 to 80,000. But in Uganda, there's only 5 neurosurgeons for 30 million people. For example, in the faculty here at Duke, we have 15 neurosurgeons on the whole faculty here. Back. When I went to Uganda the first time, I went to Malago Hospital, which is their national referral hospital. It has 1,500 beds, featured heavily in The Last King of Scotland, and it had 1 ventilator for the whole hospital, and that was not in the operating room. We went to visit the intensive care unit, which was basically empty beds. Similar thing in the recovery room, 5 empty beds and nothing there for helping the patients afterwards. And if those were bad, the OR was even worse because the OR had a bed, 1 paddle defibrillator, which I don't think does much good, and no ventilators and no monitoring equipment. They did surgery like we used to do surgery in the 1930s. This gentleman on this page was the one that really got me fired up about trying to do something. They had saved his life heroically with a hand drill to get through the skull, a braided wire to cut the bone, and using gauze to dab off the brain to stop the bleeding, and actually saved his life. He was involved in a road traffic accident, which wasn't mentioned today, is that number 3 leading cause of death and disability in the East African countries. I came back the next morning, he was gone, and it turned out what happened was the power went out in the middle of the night, the generators came on, but the ventilator reset to 0, and there was no monitoring equipment, so for 20 minutes he had no ventilation and was brain dead. So what the goal is to try to build a place where there's problems, huge problems in technology and equipment, there's huge problems with needing bigger solutions. So we came up with this idea of twinning U.S. academic medical center like Duke with Makerere University and Malago Hospital. And part of this would be bring technology because they needed technology. And 11 days after I got back from Uganda, we got our first piece of equipment, and now in my hands I had a better thing to coagulate blood vessels in the brain than they had in the whole country of Uganda. I went to the surplus store, and in the back of my trunk of my car came back with more monitoring equipment that they had in the whole hospital at Malago Hospital, automatic blood pressure cuffs and oxygen saturation monitors. Even better was we started collecting other things that are much bigger, like 400-pound anesthesia machines to put in the operating rooms for patients, and we garnered 11 of those from the Duke program. And monitoring equipment, which was hard to come by, we had now more monitoring equipment than the whole hospital stacked in my little lab up in Duke South. By the time we were done, we had 9 tons of equipment worth about $1.25 million, and we were able to basically renovate the 6 operating rooms, the recovery room, and the ICU. The ICU, by the way, was nicknamed No Man's Land because most people that went in there never came out. We went to Malago Hospital in 2007, had our first training. One of my ideas was we need to train every level, not just go over there as neurosurgeons, but as we mentioned, train the nurses in the OR, the ICU, the recovery room, and also train the anesthesiologists, anesthetists, and biomedical engineers to maintain the equipment. Now the recovery room, instead of looking like this, looked like a modern-day recovery room with proper beds and proper monitoring. The ICU went from looking like an empty room with some beds to having proper monitoring equipment to monitor ICP in the brain and have IV pumps and proper monitors to measure oxygen saturation and ventilators. And the biggest change probably came in the operating room, where we're able to basically put in operating microscopes, drills, anesthesia machines, and everything they needed to run a proper OR. And the best comment we got was from the assistant executive director, who said to the executive director, "We've gone from third world to first world in one day." What we've done over the last several years through the help of the Global Health Institute, the Duke Global Health Plus program that was formed with the help of Dr. Zhao and Dr. Merson and Jane Pleasance from procurement, is to take Duke surplus, and rather than just throwing it away or giving it to liquidators, to actually have proper equipment that's refurbished that will survive well in the East African environment and take it over there. And now we've taken over about $5 million and 25 tons of equipment to that hospital to try to refurbish it and get it going. We can show all these beautiful pictures of the little kids we've saved and tell wonderful stories, and that's neat, but my idea was, did we actually build capacity? And what you can see is in the first 2 years before we came to Uganda, this is how many surgeries they were doing in the operating room, and after we showed up, they had more than tripled the number of surgeries. And then the other thing we found was the complexity of the surgeries. If you look over on the far left, craniotomies for brain tumors over 2 years after we came went up dramatically. Even using their operating room, because they didn't have ventilators, went from about 30 to 40% efficiency up to 98% efficiency in just a short period of time. And the biggest change probably came when you combine the technology and the training all together and say, how many times, if you did one case in your elective OR, could you ever do a second case? Turn over the room, turn over the equipment, and that means you had to train everybody. And the year after we came, they had done it 45 times, and the year after that, 70 times. And this trickle-down approach, we felt that a top-down approach, people would say if you want to do surgery, what you should do is build up a general surgery program, do some hernias, do an appendix. My idea was if we could do complex neurosurgery in Uganda safely, then maybe everybody would benefit. And you see on the red line here the number of surgeries they were doing in the operating rooms and all the operating rooms at Malago Hospital before we came. We were very pleased to see that after 1 year they'd gone up 16% in the number of cases they'd done, but by 2 years they'd more than doubled the number of surgeries. And it was because of the equipment and the training we had brought for the nurses. We published this in June in the World Journal of Surgery, and the other part of the equation is they only have 5 neurosurgeons. They need to train neurosurgeons. So we started a combined twinning program where we're training Ugandans in Uganda, and I'm one of the co-directors of the training program, just like I'm the program training director here for the neurosurgery program. And we're going to train them slowly, and what we hope to do is go from this, where they only have 2 sites in all of Uganda, and every time they finish, the pair will owe us 4 years, and they will go out to another site, and we'll do our research and our training at the site that year, and hopefully over the next 6 years, by 2020, there'll be neurosurgeons spread out all over Uganda. So we can believe that this mechanism of twinning U.S. and third world or developing countries' medical centers, that can be done. It's a model for any medical center. And by bringing the technology with our Duke Global Health Plus program and the training, that we can make a big difference. Thanks.
Great. Thanks, Mike.
It's great to be on this panel. So since we might be running out of time if I go into all of the details of the stuff I might talk about, I thought I'll give you the snapshot right at the very first slide. So what I want to talk about is our work on impact evaluation, and basically the work we do tries to answer 2 questions. A, does it work, and can we make it work? And the simple answer is we don't know, and we don't know. So that's, if I don't finish, you know where I was getting. So I want to give you an overview of the research agenda that we've been trying to build up. Most of our projects are essentially evaluations of health sector policies and looking at innovations in the service delivery sector. As you heard this morning, service delivery is the next frontier. But it's not that we don't have the technologies. It's that we've not yet been able to effectively implement them and deliver services where they're most needed. The research projects that we've been trying to develop essentially combine the policy and academic objectives And essentially, the goal is to come up with rigorous policy that can support evidence-based, rigorous research that can support evidence-based policies. I talk about impact evaluation projects, but the way we've thought of impact evaluation is that it gives us a really nice window of opportunity, a foot in the door, if you will, to facilitate rigorous research in applied economics, to understand the underlying behavioral mechanisms that help us understand why some policies are successful in bringing about the change they started out to or aim to, and some others fail. In order to do all of this work, we started this organization. It's not really an organization, it's just a ragtag group of colleagues of mine. We call ourselves Cohesive India, which is the Collaborations for Health Systems Impact Evaluation. Sorry, I get the name wrong. It's up there. We work in a number of states in India, mainly in Bihar, Gujarat, Karnataka, and Kerala, and was co-founded with Grant Miller, Marcos Vera Hernandez, and Jerry LaForgia, who are from Stanford, UCL, and UCL is University College London, and the World Bank. And the idea is to build large teams, multidisciplinary teams of collaborators, including anthropologists, sociologists, biostatisticians, economists. I'm sure I'm forgetting others, but a large team. And we focus on various research topics. Of course, we evaluate policies, but we also try to study supply-side incentives, try to understand where the demand for higher quality care comes from. In a lot of global health debate, we hear about improving quality, but nobody asks who's going to pay for the quality. Yes, donors like to pay, governments might pay, but do the end users really care? Turns out we don't really know. Technology adoption, what drives local level providers to adopt different technologies or not? Again, those are the kinds of questions we don't have much information on. Demand side subsidies is something that we are focusing very heavily on and trying to understand. Unfortunately, it's not something we know very well how to do. Much of our global health delivery systems for a long time have been supply side driven. And to take the entire subsidy system and shift it to demand side so we can think of better technology adoption that is responsive to the needs of people is probably the way to go in future. But again, we don't have the evidence. So let me quickly try to give you a couple of examples of projects we are working on. So this one looks at evaluation of policy in India, where there were vouchers and conditional cash transfers for women from below poverty line households to seek obstetric care in the private sector. And in addition to the evaluation of these policies in the two states I mentioned here, we also try to do a cluster randomized trial of financial and non-financial incentives to the providers. And the idea is that given the right set of incentives, providers may be able to innovate in ways which we cannot predict ex ante, and let the power of innovation and private sector delivery demonstrate what's possible or not. And in the context of this, we are also studying technology adoption as well. The second project is an evaluation of telemedicine and social franchising models of delivery. And the idea there again is that telemedicine has immense promise. In fact, just this morning I was on a call with the Gates Foundation, and they were telling us that the government of Bihar was so impressed with this pilot program that they're starting that they want to now adopt it in other districts and scale it up statewide to use cell phones to deliver care. The problem is there's no evidence whether it works, how well it works, and what can be done to make it better. So what we find is this systematic enthusiasm from policymakers to adopt technologies, which is great, but we still don't know if the evidence actually matches up with the enthusiasm we see. So some of the other research questions that we'll be looking at include how households respond to quality. One of the theories is the major failure in these markets is lack of information. And if indeed that's the case, maybe providing better information can bridge those gaps. We don't know whether it will or not. And this was a point about the Global Health 4.0, the collaboration is, you probably have seen in the New York Times these big op-ed articles about how India is in the process of doing 2.4 billion retinal scans to uniquely identify people. So we are collaborating with that project to be able to uniquely identify people and understand their healthcare behavior and sort of leapfrog many of the challenges we've had with incorporating technology into healthcare. So, like I said, I have no answers, and oh, sorry. Oh, yeah. Like I said, I have no answers, and all we have are questions, and hopefully in about 5 years we'll know something from the stuff that I find out. Thanks.
Moshi?
Oh, sorry.
I'm going to talk about a program we're implementing in Tanzania at KSMC, Kilimanjaro Christian Medical Center. And I want to tell the audience that KSMC and the Duke has been collaborating for the last 10 years. So as you will celebrate 5 years, it's a mature collaboration. And we have a unit of purpose. So if you look at the health systems in most of the sub-Saharan African countries, including Tanzania, human resources for health is one of the challenging issues. And actually, the key issue is we have a shortage of people who are working in health facilities, whether you're talking about a primary health care facility, a dispensary, or a health center, or a hospital. In the hospital where I work myself, we are supposed to be having 120 doctors, but we work with only 55. We are supposed to be having 550 nurses, but we have only 232. So that's the magnitude of the problem we have with the human resources. And if we are really talking about effective health care systems, I think human resources for health is one of the challenges we face on a daily basis. This program called MEPI, Medical Education Partnership Initiative, has a goal of establishing or enhancing and supporting medical education through a partnership between our colleagues here at Duke and in Tanzania. But there are several other universities that are implementing the same program, because NIH, together with PEPFAR, is funding other 11 programmatic awards. And ours is like 10 million over the next 5 years, which means we have a budget of about $2 million every year. Now, I think what we thought at KSMC is that we have an undergraduate program which is producing doctors. The program itself started in 1997 with an incremental intake of students. It started with a very few students. Last year we enrolled about 120. This year we are going to enroll about 157, meaning that we have more students and very little capacity. So we thought that one of the areas that this project can do is how best can we use resources available on the internet, for example, to enhance the teaching and training of health workers in Tanzania. So one of the key activities we did was pulling the fiber optic cable from our telecom company to the hospital, and then laying all the pipes or the wires so that everyone can have access to reliable internet. That one we have already achieved, but also the other thing was, how do we look at our learning management system? And we knew that at Duke they had the Blue Docs, and we thought that that could be one area we could actually, within our partnership, use that one to enhance learning, so that all the learning materials, all the assessments can be pulled together in one area, and then both faculty and the students can access these materials. We have also noted that we needed to have a different approach to training health workers. And one of the ways we are learning from our colleagues is team-based learning. Others call it small groups learning and so on. But I think team-based learning is very good in enhancing understanding between the trainees, but also maximizing the use of few resources in terms of faculty to impact knowledge and so on. After pulling this fiber optic cable for internet access, we also established a computer laboratory which can be used by students to access information. And for student assessment, we have started actually for the first time in Africa using the National Board of Medical Examiners exams to assess our own students, and we think that that is a very good in benchmarking the quality of our education. MEPI itself is serving as a platform for coordinating other programs going on at KSMC. For example, we have the Building Stronger Universities, which is a Danish initiative for promoting higher learning. but also we have collaboration with the Nijmegen University, and we think that we can have real linkages within the two development projects. I think in terms of achievements, we have several so far. As I said, one was pulling the cable so that everyone has access to internet. But the other one was that really all the students who are entering this year, we are going to have to dish out them handheld gadgets. We have chosen to have the Toshiba Thrive so that they can use to access the information. We're also going to introduce mental research awards so that students are interested in doing research right from the beginning. And for teachers, also we have something we are calling Education Innovation Awards, so that teachers or faculty can innovate in the way they do student teaching, assessment, and so on. And we are going to have a follow-up with the NBMB testing so that we continue to gather data and so on. And because we want to track those who graduate from our own schools, we are going to have an alumni office and have a database of all those who qualify from our university so that we know where they are and what they are doing. I think that is mostly what we have achieved. Thank you very much.
And Kate.
Okay. So I am your 16th speaker. And I knew that when I was asked to be on to speak today, and I'm very honored to speak with, to be on the panel and be a part of this event. It's been wonderful. And so the slides that I'm going to show are pictures from around the world, and I'm going to talk about the integration of, and the potential integration as we think about the future of different kinds of services where we have an opportunity in low and middle income countries both to learn and to put in place models that may be more effective and efficient than those that we have created here in the United States. So the teams, the research teams that I have the honor and pleasure to work with here at Duke and around the world focus on understanding why individuals, communities, families don't perhaps behave in the way that we health professionals might want them or expect them in some cases to behave. Perhaps aren't engaging in care in the way that we think they might. So why do people continue to engage in high-risk behaviors when they know it's a risk to themselves, to their loved ones, to others? Why do they not get medications even when they're available? So we need good care, good technologies that we've been talking about here, good medical care systems, well-trained people. And as we do that, we need to think about individuals who, even with that, aren't going to be possibly behaving and engaging the way we would expect them to. And we find that here in the United States and around the world. I spent many years, a number of years, working and living in low and middle income countries before coming back here, and I learned two things from my friends and colleagues there. And one is that health behaviors and diseases, so behaviors that put one at risk for diseases and health promotion that make us better, need to be and are in the context of people's lives and the lives they're living. So we in the medical care system or as health providers, we see people with diseases, we see the behaviors that they're engaging in, but those behaviors and diseases are there within the context of their families, their priorities, their children, the neighborhoods and environments that they live in, the opportunities that they may have. So we may say, why aren't you taking this medication that can keep you alive 5 years from now? But if the opportunities 5 years from now look perhaps worse than now, or I'm not even sure if I'm going to live that long, then that's going to affect whether I decide to engage in a behavior that's a change and that is difficult for me and perhaps not as pleasurable. So we need to look at diseases and behavior in the context in which the lives in which people are living, including policies and the structural situations that they're sitting in and living in. And that the models that we found to work, particularly in the DRC, at literally, stopping a measles epidemic on the border of our regions and getting women to be more integrated into the healthcare system when they were delivering children, was actually working with people in the community who were the natural leaders in those communities, working with midwives who were in the communities, and bringing them into the healthcare system and really incorporating them and training people up. And we found that when we did that, we were able to better understand, because they would then tell us about what was happening with people and why they were engaged in perhaps not behaving rationally as we would see it, and explaining that to us. So I brought those lessons back to North Carolina when I came to work here and to do research here. And that's a point that I really wanted to bring home here, is that we can learn from other countries. And in some of the studies that we've done, I'm not going to give you details about those studies, but we have learned that in Tanzania, for example, that one of the largest predictors of adhering to HIV medications is traumatic events in the life course, particularly during childhood. So adherence to medications as an adult, one of the strongest predictors is traumatic events during childhood. And we found the same thing here in North Carolina in the Deep South, in one of the largest studies conducted in this region where we followed people over time. We found in following orphans that one of the biggest predictors of children engaging in excessive labor is actually the caregiver's need. So providing uniforms for a child or education fees may not alleviate the need of the family. And in terms of health, that one of the strongest predictors of kids' health is the health of the caregiver. So I hope that as we look forward to the future and creating health systems, that what we'll be able to do is to not make the mistakes that we made here, that we will incorporate services, that we will not marginalize social services to the ancillary, something we do if we have enough money, and if we can get to it, then we'll go out and we'll do case management and we'll deal with mental health issues. But it's actually incorporated into the systems, and that we don't do what we do here also, which is divide funding by diseases and by categories that make sense to us, because that's where our funding comes from. And so those are the messages I wanted to give today. Thank you.
Well, thanks to you all. Again, I'll ask questions for about 10 minutes and then throw it open to all of you here. A wide variety of areas that you're all working in. And so I want to ask some broader questions than I've been asking in some of the other panels. One of the criticisms that's often made of research coming from academic institutions is that it's academic, and it doesn't have direct impact on people's lives. Can each of you talk about how some of the research that you've done has made a difference to the people's lives where you're working? Mike?
Yeah, so I think I would say that us going back and looking at the data to actually show that we'd made an impact and built capacity. We took a neurosurgery unit that was kind of a throwaway because they did very barbaric stuff and nobody lived and things like that, and turned them into a high-tech department that was able to do sort of the cutting-edge work in that whole department of surgery. When they talked to us what difference it made in their lives, they said, well, we have a new pride in our work, and whereas before in anesthesia, for example, they had one resident maybe every few years show up to get trained. And there's only, if it's bad, there's only 5 neurosurgeons in Uganda. It's horrible. There's only 10 anesthesiologists in the whole country. Now they had people coming by the droves. Our running joke was before all I got was strong hands from pumping the bag for the whole surgery. And now we'd raised the level of sort of their pride, and people were wanting to train in those levels. And when they saw we'd actually made an impact, the look on the nurse's face when we showed them, look, you guys did 3 times as many cases this year. You did multiple cases on the same day, 4 cases in a day. That's a good day at a Duke OR if I get 4 cases done with turnover time. So they had really took a lot of pride, and we really saw a change in their attitude toward their work and a willingness to really jump in and try to make an impact at their hospital.
Thanks. Manoj?
I think we're, in some sense, fortunate to work in health systems in that it's one of the fields where the link between academia and policy is much more clearer. So in that sense, I see that most of the work that we do actually touches lives a lot more than if we were in, say, basic sciences. That said, to give you, concrete examples of how hopefully lives are being touched is when we provide evidence to governments on whether programs work. Some of these programs have been celebrated as successes of public-private partnerships or policy interventions. But if we come back and say, well, it really doesn't work, that actually makes them stop and pause. And we are talking about hundreds of thousands, probably millions of dollars at stake, which can actually be used to improve something else.
Have you seen that happen where they'll use the impact evaluation or cost effectiveness data to drive their funding decisions?
Well, we are in, so I was actually hoping to show some results today, but the state government has given us a bit of a gag order till we sort out whether they believe our results or not.
Just between us here.
Yes, just between us. So, enough said.
Going out of the web, yeah.
Yes. Hence. But yeah, they do. And I've actually, one of the arrows in there is the state called Kerala, where I'm advising the state government on health sector reform. So governments are increasingly very open to listening to academics and helping incorporate what we've learned in our research into policy. So
great. Moshi?
I think if you look at health systems, what is called as strategic information is one of the key pillars of any program. And I think if you want to have a very good information, then you have to do research. So I would argue that actual research has helped health systems strengthening. And I can also argue that the amount of money now being provided by PEPFAR is out of evidence. Because I think PEPFAR was providing a lot of money for drugs, HIV test kits, and so on, but invested very little in capacity building, system strengthening. But when the information was made available, data was made available that, look, you are buying drugs, you are buying test kits, who is going to do that? Where are the people? And I think that's the value of research.
Okay.
So one of the things that we need to know is that policies are going to be made whether we're there or not. And one of the difficulties that we face is being at the table as policies are being made. So if there's not evidence, those policies are going to be made without the evidence. Some of the examples from the work that our team has done is we have a book where we had case studies and narration, and that book actually reached a lot more people and providers, policymakers than many of the manuscripts that we put out that have tables and data runs. So by telling people's stories and having the data around it, we were able to reach people who actually make decisions in a way that I often don't, I'm not able to do. And that work then got us involved in providing evidence for the Southern AIDS Coalition around HIV/AIDS, and then eventually into the Ryan White reauthorization talks. And then in the work that we do around orphans, we now are meeting regularly with UNICEF and had some say in the alternative care guidelines that came forward. And the reason that we were able to be there, I would attribute in part, is because we got a lot of news coverage for the results that were fairly controversial, that then when we had been asking for about a year to be able to have a closer collaboration, had gone to meetings, but it was really the news coverage that then they said, okay, we'd better be talking with you, and we were then able to move forward. So, so those are the kinds of things that we do.
Richard,
yeah.
One thing I can say is we have one one of our students who had a Duke Global Health Scholarship this summer, she spent the summer in Rwanda and in Kigali in the capital and in Kampala in the capital. And if you go through those two cities, you'll see in Rwanda they have laws where the motorcycle riders and taxi people that are riding the motorcycles have to wear helmets, and it's like 98% wear helmets. In Kampala, it's exactly the opposite, only about 2% wear helmets. And about a year ago, it made sense, everybody should wear helmets, so President Museveni said, okay, they're going to wear helmets. Well, they started confiscating the motorcycles of the people not wearing helmets. There was a big strike, there were protests, and then Museveni said, well, show me the data, and nobody had any data. And we've just spent this last summer, June Tibalika, one of our medical students who's interested in neurosurgery, spent the summer there gathering the data, and now we have data to basically show, we compared the two cities, these two capital neighboring sister city, countries, to show that the people that are not wearing the helmets come in with more severe closed head injuries and they have worse outcomes. Some stuff didn't pop out like we thought it would, but the data is there now to be able to hopefully take it to the Ministry of Health and the government and say, look, here's the comparison and there's actually a difference, and we hope that'll drive policy.
Great examples. There's a question for you, Moshi, and you, Mike. How do you avoid the issue of brain drain? Training staff, having a big need in country, but avoiding those who are educated, then leaving country for places where they may make better income. Is that a concern? Is it something you see?
Certainly, brain drain is a concern in Tanzania, and I think we have two types of brain drain. What is mostly reported is a drained brain, people going outside the country. But also you can look at within the country, people moving away from rural districts to urban centers. Yeah. So maybe we should address the two separately. For Tanzania, I think we have had experience in the past that people were going either to South Africa, Botswana, and so on and so on. But I think increasing over the years, most people who are trained in Tanzania have remained. We have fewer who are still going. And one way of addressing this one, the way we are doing it is training people to work within the country. Yeah. I think that is really key, that you orient the trainees not only to work within the urban hospital, but also expose them to work in rural districts, rural hospitals, so that by the time they graduate, they understand both the scenarios, what it is to work in rural areas and what it is to work within the urban centers. And for that, we hope, and there is also evidence that students have been exposed to these two scenarios. The tendency is they are going to remain behind. Because if they are trained in big hospitals in urban areas, when you send them to rural areas, that's where the persuasion comes in, that they would like to leave and go outside the country. So we have inbuilt that one within our program, that the rotations, the clinical rotations for our students will be both at KSMC, the big hospital, but also will be utilizing rural hospitals for their clinical clerkships.
We've approached that because you're exactly right. To work at Duke, they would have to be certified by the National Board of Medical Examiners, and if they get that, then they could train here in the United States, and they're probably going to stay here. And they've seen that in Africa when they go to South Africa, when they go to London. So what we did is we spent many years, we set up a curriculum that parallels the Duke neurosurgery curriculum for them there, and working with their College of Surgeons, we have a combined now fellowship in COSEXA, which is a college of surgeons for Southern, Eastern, and Central Africa. So we have 4 countries actually involved: Kenya, Tanzania, Ethiopia, and Uganda. And these neurosurgery residents will train for probably 2/3 of the time in their home country, but then we'll go out to these other spots. And the deal is, we're paying for part of their education, the government's paying for their graduate work, their M.Med, and the hospital's providing housing. They're going to be, as they call it in Africa, bonded for 4 years. And when they get bonded, they're going to be sent to a district hospital that's a bigger district hospital. But if they go there and there's no equipment and how they got trained how to do brain surgery, it's silly to send them there. So when they go that year, we're going to use our influence from the Duke Global Health Plus program to take equipment there and set them up, not as big a scale as we did at Malago, but on a smaller scale, so they can actually do proper neurosurgery in that hospital that's further away. Because right now, if you're in Gulu and you get a head injury, you're 12 hours away from Kampala, you're probably going to be dead. But if there's 2 neurosurgeons there, we're going to send them out kind of reverse Noah's Ark, pair at a time, send them out there, and then we'll go there right after they show up and bring a whole team and bring the Ugandan neurosurgeons who are the faculty out there to work with them for a week or two and have these sort of mission weeks where they go out to these other hospitals. And hopefully then with the government providing them a consultant post after 4 years so they'd actually have a job, you know, that pays through the government, that they'll stay there, and that'll, like I showed on that map, kind of spread things throughout the country.
I'm going to ask the panel another question, and then I'll turn to you all in the audience. One of the things that's always struck me in public health is an issue, Kate, that you raised, and that's the competition between diseases. You see it in the U.S. around public health at CDC. When I was there, the chronic disease people were always telling me why they were more important than the infectious disease people, and then the injury people were telling me why they're totally underappreciated.
Exactly.
And a much greater burden on society than the chronic disease, and we're undercounted. And in the global sphere, it's even worse, because you're often working in countries where to work on one disease pulls the talent away from something else. Nothing competes as poorly, I've seen, as people who say, well, health systems are where you need to invest, because health systems help support everything. Well, there aren't a lot of advocacy groups out there, you know, the Society for the Promotion of Health Systems, or that kind of thing. So,
just created that.
Oh, charter member. So, how do you avoid that? How do you argue that resources should be there to support the infrastructure for everything? How do you support evaluation, the impact evaluation that you're doing that requires people who are trained in that methodology? But you know, the people in HIV don't want to pay the impact evaluator who's going to be looking at the motorcycle helmets. They're there for HIV. And what are your thoughts on this? I'd love a solution. Hey, it's 5 o'clock. We need solutions.
We'd love it. We'd love a solution.
Yeah.
No, I think I do think much of it comes down to financing and how we spend our dollars, and the more that we can, and other currencies, and the more that we can show and demonstrate that by working together that we'll have more efficient systems, and particularly in regions where there aren't a lot of resources to begin with, that we're going to be better off. And so we need to continue to keep doing that work and getting it into the hands of the policymakers, the people who are making funding decisions. And that second step, as you had alluded to in your previous question, is a really difficult one, because the researchers don't, both on the push and the pull side, we're not often connected up with the policymakers, either because we're not getting out there, that's not what we're funded to do, or because we're not being asked. And so we need to keep showing that this is the way to really make a difference within communities and to reduce the burden and reduce costs, and get that information into people's hands.
Sorry, go ahead. You go ahead, please.
I think I will propose that one way of reducing this competition is that in the design of any program, we should really think about integrated approach. And integration at many levels, at a policy level, that we are having policies that are really integrated. If you have a program or a policy drive that is aimed on at one disease, then you are sure that even the flow of money, resources will be towards one disease. But if you have national policies, for example, that are integrated, they look at health as a whole, then maybe that can reduce. But that is also at a policy level. When it comes to implementation like ours now, when you are training health workers, I think should be look at multitasking instead of training people to only one job. Because what we have now is we have experts even at a primary level, which is very damaging for the health system.
Manoj?
I was going to point out that, for better or for worse, as of today, there's actually a lot of resources on the table for work on health systems. The problem, as Kate mentioned, is that most of us in academia have not been able to reach out to policymakers and earn their trust. In fact, many governments, donors, have acknowledged the fact that not having rigorous evaluations of their policies is one of the main failings so far. And they are willing to put the money into it. The problem is most of us who want to work in that space are not able to work with them. And that in effect is a call for action for those of us who work in evaluation or want to work in evaluation to reach out and make connections.
Why are you not able to work with them? What's the gap?
Sometimes it's institutional challenges. Sometimes, the way our academic systems are set up does not reward the work that you do. Sometimes it's that, you go out and evaluate a nutrition program in a country and you are able to publish it in a third-tier journal. No one cares about it. So the incentives for academics might be very different from what the real world demands. And to find that mix is actually very challenging, the right mix.
So one thing I'd say we've tried to do with this program in Uganda is everybody benefits. So we could have really built up the neurosurgery just that area, but our goal was to show the ENT surgeons and the general surgeons that, yes, we brought equipment for your operating rooms, anesthesiology department. We brought labor and delivery where women were dying because they had no ventilators up there. We brought ventilators to their area. So I think trying to lift the whole hospital up at one point is I think you need to do so you're not so focused in on one little area.
Feel free to come to the mics, those with questions. Otherwise, I'll use my reporter's prerogative and keep going here. Yes.
Hey, I'm Redford Williams, behavioral medicine at Duke. And in response to your last kind of set of things, there's no substitute for evidence. If Kate could show that having these ancillary people available to help deal with some mental health issues like depression, et cetera, actually makes a difference compared to people who don't get that intervention, that's what we got to do. I've recently had the opportunity to do some consulting with our Department of Defense, and we got a big problem with suicide, PTSD, and all kinds of other problems and people coming back. And they actually have programs that are for the people coming back. And when they've gone in and evaluated them, have they been implemented for everybody, they find that they don't really prevent anything. So we've really got to evaluate, evidence.
Thank you. Yes.
Let me just preface my question with a quick story. So one of my colleagues who helps me collect mosquitoes came back to the United States about 2 years ago and presented with flu-like symptoms in a Florida VA hospital. I won't say which one. And to make a long story short, they suspected he had malaria. They did a rapid diagnostic test, and sure enough, he was positive. The parasitologist at the time had never seen a malaria slide in her life, and she didn't know what to do. So the attending said, well, let's wait until the morning to figure out what kind of malaria he has before we treat. And he called his wife, they called us, and we said, wait, this could be an emergency, we need to know right now. We had her basically fax the microscopy slide to Iquitos, where our microscopist read it, diagnosed him with Vivax, and treated him appropriately. So the question is,
global health.
Global health, number one. But number two, really, what do you have to have expertise in everything? Because this last point you're making, you really can't supply resources to address every health problem. Right. And with chronic disease becoming such a big factor in most societies, especially in the Amazon where I work, capacity building is mostly in vector-borne diseases, more of these emerging infectious diseases, not so much in chronic disease, but that's going to be a huge problem. And so we have, for example, 2 fathers of our study team that have died of diabetes, never diagnosed with it, and that was in the Amazon. Mm-hmm. People have never seen it before. And should capacity building be made in areas that the burden is most right now or most where we're going to be expecting in the future? Just a question.
We'd like to field that.
So I can talk about one of the points. I mean, that was a loaded question. I'm not sure I can answer everything. And as I said, I don't know, right? My answer is I don't know for everything. But the point is, yes, we don't need centers of excellence and we don't need expertise in everything everywhere. That is just not going to happen. We can start with something very basic. If we can improve basic quality of primary care, and that does not have to be at the level of the specialist. And that does not even need trained MDs. A lot of the things that save lives do not need 7 years of medical education. And if we can start with that premise and have a good referral system, a lot could be done. That's precisely why telemedicine seems so attractive at this point. And what Bill described was exactly that. Telemedicine doing what it, showing its potential. But we need to figure out sustainable systems of referrals that can actually work when we want it to. We don't know, we're not there quite yet. But if we have a strong primary care system and a system of referrals to establish centers of excellence, then why not?
Kate?
Yeah, and I think this is an excellent area where we, again, look at the efficiencies and setting up systems where all of the different teams are working together and across diseases, and you've got multiple providers and getting appropriate provider levels. There's a study just came out looking at non-physicians who are trained to do C-sections in some places. So can we get, provide excellent services in regions and then figure out what the levels are for different types of services as we roll out? Some of the evaluation programs we've been looking at have been looking at providing mental health services, cognitive behavioral therapy with lay providers, and seeing how that works. So what level, we don't understand yet, while we have technologies and a lot of evidence here, we don't understand at what level we need to provide them. And I think there are a lot of efficiencies that we could have and have really excellent care, and we can learn from that care and apply them here in Durham also.
I want to add one thing that Kate's comment reminded me of. It's not that in many countries around the world, it's not that we don't have providers. The big problem is that we don't have evidence that providers are doing what they know already. There's a huge gap between what we call the no-do gap. And if you want to improve the quality of care in most rural areas, let's address that gap first. Because it turns out that when you ask providers what would you do optimally under a given set of circumstances, what they tell you versus what you observe them doing, there's a huge gap.
And what's the big driver of that gap?
That's the million-dollar question, is we don't know what sorts of behavioral responses would drive them. Would they respond to incentives? Is it financial incentives? Is it non-financial incentives? What motivates physicians? Those kinds of questions have not yet been answered. And in some sense, if we want to improve quality and outcomes, it's those questions that we need to seek to answer better.
Well, our day is winding up. My takeaway from this panel and the three other panels is that there are enough questions to keep the Duke Global Health Institute going for many, many decades. Much to be done, and Duke has the people to address a lot of these complex issues. So I want to thank our third panel. And before I turn it over to the Duke Provost, I want to say it's been a real privilege to be here today to moderate these panels. The incredible breadth of work that's going on here. It's the first big Global Health Symposium I've attended where infectious diseases were not front and center as the main thing. And it really gives a sense of how much work is going on in global health and in such important areas. And the equation of global health with tropical medicine that our keynote speaker was talking about in terms of global health version 1 is so far from where we are right now.